On behalf of Ormco, Shinhong, our host, and our regional distribution partners, I'd like to thank you all for taking time out of your busy lives, busy practices, to come and spend 2 days with us at this event. As we prepare for meetings, there are a number of things we do, and this forum, we really came in with 3 key goals. Number one, we wanted to assemble the best group of speakers possible, experienced, innovative, and a combination of East and West, so that the cases you'll see on the screen will be reflective of the patients that walk into your office. Our second goal was to come up with a range of topics that address your needs. As we travel around the region, we talk with many of you, and there are some common concerns, some interests, and some issues that you need help in dealing with. And so we hope that over the next 2 days, the topics we've selected are particularly relevant and address your needs. The third goal is to create an environment for learning, formally through lectures, but more importantly, informally. The conversations you'll have with friends, with colleagues, and with our speakers outside the lecture room. To facilitate that at this event, we have done a couple of things. Firstly, we have a cocktail party that we invite you all to attend at the end of today's proceedings. It'll be held outside this area. Our speakers will all be present. And another idea was something we tried at our last forum in Thailand, and that was the lunches will actually be standing buffet. Our speakers will all be present, available. If you have questions and you would like to seek one of them out, I encourage you to do that. You know, as we hold forums throughout the world, there's one message that seems to resonate through that's common to all, and it's the phrase commitment to excellence. Our speakers have a commitment to excellence, and you have all demonstrated a commitment to excellence by being here. And our first speaker today is somebody that truly lives that mantra. Dr. Tom Pitts earned his undergraduate dental education at the University of the Pacific School of Dentistry and his orthodontic specialty training from the University of Washington, where he was a classmate with Dr. Damon. He served in the Army Dental Corps before starting a private practice in Reno, Nevada. He is past president of Nevada State Orthodontic Association and the Northern Nevada Dental Society, and served on the board of directors of the Pacific Coast Society of Orthodontics. For many years, he's been a full-time consultant to orthodontic practices. Dr. Pitts is a fellow of the International Academy of Dentistry and the founder of the well-respected Progressive Study Club. He lectures throughout the world on clinical and practical management efficiency and serves as an associate clinical professor at the University of the Pacific in the United States. Tom's been involved in the Damon Project from day one, and it's my pleasure to welcome him to the stage to begin our meeting. Thank you, Tom.
I'm very happy that you all understand English, and I'll try today to not go too quickly so that you can understand as much as possible of what we're doing. It's a great honor and a pleasure for me to be here in Korea. I came the first time to Asia about 4 or 5 years ago, and I'm thrilled to see the number of great orthodontists here in Korea. We have to have blessings for Japan. We're going to have one Japanese speaker, but Toru, of course, he stayed with his family this weekend. They had some projects to do to help some people. But anyway, that was a horrible thing to happen. We went through that. It seems like Mother Nature is pretty violent the last few years. We experienced that in Phuket and Indonesia a few years ago. I'm really thrilled with the number of great speakers that we have on this program. Of course, John and Sabrina and Chris. I've learned so much from the Asians, including the Koreans, Dr. Kim and Dr. Beck and several. Rung Zi is from Bangkok, Thailand, and I have to give thanks because he's drawn so many beautiful images of teeth and brackets, and also I've got to thank Duncan Brown. Some of you have met Duncan, but he's from Canada, and you'll get to know him more as he comes, but he's helped with a lot of teaching materials throughout the world and slides of things and consolidating ideas and philosophies. I also have to thank Ormco and Mr. Mang and for inviting us, and particularly, I know you've had several forums here in Korea, but this will be the first one that we've attended. We've got a new learning center in Southern California. Ormco, in affiliation with Cybron, the mother company, built this learning center, and with it comes a clinic in which I'm seeing some patients in that clinic and testing various products, and then we can use those patients to have sort of an in-office teaching, and it's a wonderful facility. In fact, I think we're going to have a master's program for the Asians this summer, and it's really a wonderful center. We can do hands-on work with bracketing and insignia and wire bending. So I hope that many of you could enjoy this learning center. And as I go around the world, what I see is cases and questions dealing with proclination of the incisors and how to deal with that, as well as arch development, how to incorporate that into the cases and what cases can be developed. Buccal torque control as we develop the arches so that we don't have the molars proclined. Also incisor torque control with arch development. And where's the best place for, depending on the situation, where should the inclination of the lower incisors be? So what I'm going to do is I'm going to address that this morning, and I've picked out a few cases that I want to look at intimately, and I want to go through every step possible of how we dealt with the torque and how we dealt with the arch development and what happens. Very few orthodontists today fill up the slot when finishing cases. In other words, there's not too many that still use the 2125 wires, especially with the passive self-ligation. What we've found is that the 1925 wire is about as big as we go, at least to date. Now, I'm sure with advances in wire technology, we may sometimes get a little bigger wire, but even advocates of 2125 use lighter wires usually with vertical elastics to finish the occlusion. With the 1925, we have somewhere around 10 to 11 degrees of play in the slot. So it makes torquing a little bit challenging as we deal with. That's why Dr. Damon and Ormco went to variable torques. So one of the things that I see continually as I go around and I work with my students, I teach at University of Pacific with Dr. Frost in the back of the room. And by the way, I'm excited about the speakers that are here this meeting. And I'm going to mention some of Dr. Badawi's material, but tomorrow morning will be real exciting to see Dr. Badawi himself and how he's applied that clinically from his research table. But I feel that the case that the patient is not finished with treatment until we can get the torques or the inclinations of the teeth as perfect as possible. And I worked very hard at studying that. This is an advertisement from GAC, and what Dr. Roth said many years ago, before we had active and passive self-ligation, he said, we need to keep the wire, the rectangular wire, against the back of the slot to express the torque. And of course, we never really agreed with that. So what we've done is we've studied this, and in order to get a torsion type movement and inclination of the root of the tooth, it takes, depending on the size of the tooth, somewhere between 70 and 120 grams of force. And so this was a little study done by Steve Ward in Canada, showing, and this is Innovation C, which is, has an active clip. And what he wanted to do was just see how much force was really holding that 1925 wire against the back of the slot. As you can see here, there's not enough force to upright those teeth even without the bone. And as it rotates, you'll see some teeth that actually move. See the tooth move there. So what we've found with active clips is that they do not increase the torque control as far as we can tell, and there's been various studies, and there seems to be a metal fatigue which reduces their effectiveness. And that's why I've really grown to love the passive self-ligation, where we have a tube on every tooth. And then looking at the wire in the slot, so where the 1925 wire does not touch on the corners, then that's what's called a passive no couple situation. So now, as if there is a couple with the corners of the wire, then that's what is called a holding couple in one direction. And I think that's good terminology. Now, of course, if you have to bend the wire to get it in the slot, then you've got an active couple, or a torque happening. Because torque is when you're actually getting forces to move the tooth. So that's why Dr. Damon and Ormco went to variable torques, so that they could help us so that we didn't have to bend the wire too much as far as third order bends. So if you look at a regular torque bracket is plus 15 degrees. Whoops, went the wrong way. It's plus 15 degrees. And so if that is in the wire plane, then when the tooth is perfectly upright, then there should be very little coupling involved, and so that's why they pick that to be the average torque, because once you get the tooth in the proper position, of course it depends on the occlusal plane, but it's pretty well passive. Now if you have a low torque, that means you typically have a holding couple to hold the tooth from going and having lingual root torque, so it's keeping the root forward when you have a low torque bracket. So this is typically plus 2 on the upper central on the new cues. Now they have the super torque, the high torque, and so that is used on extraction cases and class 2 cases where you need heavy rubber bands to keep the root back from having too much lingual crown torque. And so that's why this whole variable torque was set up. And so I wanted, now in Asians, and in, this is a normal average 15-degree torque flipped upside down, showing that you can get active torque to bring the actual root forward of that upper incisor. And we're going to talk about this as we look at these different cases. So, in great results, we want not only to have a great functional occlusion and deal with all of these issues that are on American board cases, but we also want beautiful aesthetics. And I think that the labial inclination of the teeth are one of the biggest factors in how a case looks. Yes, we want the smile arc, and we want to minimize the buccal corridors, and we want to have nice incisal display. We want to have beautiful lips. But this, if we don't have the right inclination of these teeth, then we're not going to have as beautiful a case. So we're enhancing board standards by adding facial and smile aesthetic to the board's functional occlusion. And I think with passive self-ligation, I've been able to really enhance the aesthetics more than I could before. Now this is an Asian patient, and her profile looks very good. She has a slight class 3 malocclusion with upper crowding, slight lower crowding. She already has proclined lower incisors, and the upper incisors are in fairly good inclination at this point. As we get down the road, this is not an atypical scenario, trying to do it non-extraction. What happens is it's so easy to end up with very proclined incisors. So as you look at the case now what do we do? So I think the options we have is, number one, we can extract bicuspids. Number two, we could use mini screws a la Chris Chang and John Lin and some of the Koreans to distalize the arches, which works quite effectively. We could leave them proclined because her lips are still in very good position. Or we could attempt to use the passive self-ligation to detorque the teeth and widen the arches. So these are the things we have to contend with, and I think it's very common in the Asian population to deal with this. And that's why I wanted to address this today in showing you some cases. This is a Korean gal. Her parents are from Korea, South Korea, Seoul, and they moved to Reno. In fact, the mother does not speak very much English. But the children are both class 3 patients. And this was, like I say, a breakthrough for me, because what I had initially talked to them about was doing orthognathic surgery with orthodontics. And so, as you can see, she has a deficient maxillary situation. You can see the depression below her eyes, and so her maxilla is definitely retrusive, and she's got a large mandible as well. I could not get her edge to edge in her bite. Of course, she's got more upper crowding than on the lower. Now, some of you have seen this, but I wanted to look at this in detail and show you exactly what I did, and in hopes that you can see some of the possibilities that happen with passive self-ligation without the use of mini screws or without the use of surgery. Now, we're getting a lot more Asians in America. not only in Reno, but of course in the San Francisco Bay Area and in the coastal areas, we're getting a large population of Asians. So we have maybe 20% of our patients now, we're dealing with the same issues that you're dealing with. So here you can see. Now typically we like to judge where we're going to position things by where the upper incisor is going to end up. But you can see here her upper lip looks fairly good. And the upper incisor, the upper central, is actually in the right inclination, and her lip looks fairly good here. So her lower anteriors are a little retroclined. Now we like to see that the facial surface of our upper incisor is perpendicular to the floor, or Frankfurt horizontal, as it were. So this line, we like to end up with the incisor in that inclination. Now to correct this class 3, it's going to take some doing in order to get it done. So what I did is I put the Damon passive self-ligation brackets on. These happen to be the Damon MX. And so now I know what's going to happen with those upper incisors. As we unravel those incisors, we're automatically going to procline the teeth. And then I've got the class 3 happening here. So I put on 2-ounce early elastics from the very first morning that we put the braces on. So she wore, I usually go from the upper second bi to the lower cuspid on class 3s with quails. Well, I actually use quails here from the upper first molar to the lower cuspid, knowing that she was quite class 3. Now she was a deep bite. She was a deep underbite. So what I did, of course, is I put some bite planes or bite turbos behind the lower incisors, which we'll see here. So this is Rung Z's illustration, but I didn't go from the second bi. I actually went from the molar, but it's the same thing. So I disarticulated the posterior teeth, and I used very light elastics, 2-ounce. Then she wore them day and night, full time. And being Korean, she was very disciplined. And she did it. She wore them all the time. Would you agree that Asians are more disciplined, I think, than Caucasian Americans? So it's fun to work on Asians, actually. Well, here we go. 5 months. So what happened, of course, is just unraveling the crowding through the round wires in the 1425 and class 3 light elastics. We ended up with proclined incisors, but you can see that the incisal tip of the upper incisors now are labial to the lower incisors. So, in the relief of crowding with the round wires in the 1425, I'm moving these incisors, and what happens as teeth procline, of course, they move to open the bite. So they'll move apically a little bit because they're rotating around this center of rotation, which is about here with round wires. Okay, so we're moving the tip of the cuspid, or the central incisor, we're proclining it and intruding it. And the effect of mechanics is the same way. So we're dealing and rotating around that center of resistance. So here, looking at it with both the upper and lower incisor, then we put on the bite turbo. Now immediately when we put on the lingual bite turbo, what happens is the lower incisor and the mandible moves down and back. So now we've already helped the class 3 a bit because we've opened the posterior bite, and So now we have this, and with the elastics, subtle elastics, actually they came back to here, what we're getting is we're getting eruption of these teeth, and therefore the mandible stays open down and back. So now here we are, and this is 5 months. So we've got proclined upper anteriors, we've got the lower jaw and the teeth moving down and back. Now we can take off these bite turbos, and we've got that situation at the end of stage 1, which is round wires and the mechanics. Now I consider 1425 a round wire because there's not much torque happening with that. There might be a slight amount, but very little. So here you see we've erupted these teeth, we've proclined these incisors, and actually leveled the lower arch quite nicely. And now that is at the end of 1425. Now I went to an 1825 copper night tie at this appointment. So now what I want to do is I want to have active torque on these upper incisors to keep the pressure, and I want subtle pressure, light pressure, to have the roots stay forward and to begin uprighting these teeth. So now there's several ways to do that. Now the way I did it on Wan Young, that's her name, is Wan Young, I flipped regular brackets upside down. Now I think there's an easier way to do that, and we're going to talk about that in a moment. But I flipped those brackets. So now, instead of having a plus 15 degree, well actually these were 12 on the MX. This is 12 and this is 7. So now I have a negative 12 and a negative 7. I put 0 degree here. I put plus 7 on this canine, plus 7 here, and I use a regular minus 1 down here. Okay, now with that, what's going to happen? I'm going to have an active couple now because I've got a minus 12 degrees, and I've put a 1925 wire in there. It's going to have activity to upright that tooth. Now when I upright that tooth, what the upper incisor wants to do is move back naturally, okay? So that's why I kept wearing the class 3 elastics. So in fact I went to a Parrot, which is a 2 ounce. So a Parrot, and I went from the upper 6 down around the canine to the upper 4 with the elastics. So I still have very subtle pressure because now I'm detorquing these teeth, and I know that they're still going to want to move distally. So she wore these full time. So now, of course, when I put them upside down, I've got an active couple. Now that can be a little dangerous too, because as we get the teeth in the right position, and we have to be careful, when the patient comes in, whenever I go to an active couple, no matter what I'm using, I see them every 7 weeks. And what I do is I feel, of course, up around the root tips on the labial of the upper, and I feel on the labial and lingual of the lower. I'm palpating that continually, because if we're not careful, we can go too far. So the way we create an active couple is, number one, we could do like I did, and we could take regular torque brackets and flip them upside down, which provides that active couple. Or we could use, particularly with the new DQ brackets that have a +2 and a -5, using the low torque brackets, then we can use a pre-torqued wire upside down. So if we take a 1925 pre-torqued and flip it, and we have the low torque bracket, then that's a very subtle force. When you have a night tie wire that's pre-torqued, it's less force than if I have a 1925 TMA or a steel. So I think this is a very practical way, and what I see happening now with the new DQs, I see myself using some more pre-torqued wires. And that way, when I get it upright, then I can take that out of there and I don't have that active couple continuing to work. So, and the other way, of course, is the bend wire. And what we want to try and do is really avoid bending as much wire as we can, even though on every case I do put third order bends of certain amount, which we'll talk about. But here we go now. I went from 5 months, so here I got to the 1825, and then 6 weeks later I got to a 1925. So 4.5 months, and here's what's happening. So she's still wearing the rubber bands full time, and 4.5 months, you can see the uprighting that's happening with this incisor, which is very positive. So now, what I didn't realize at the time, but after studying her case, what I see is with these rubber bands and with the torquing, or the detorquing, which I've got labial root torque here on these incisors, what was happening, what I didn't realize, is this lower jaw was still opening a bit. So I've got some positive things happening with the opening of the bite. And here you see it. This is 10 months where we took the tracing, and now the black is the beginning, and you can see what happened to the mandible. From the very beginning, it's opened down and back. It's taken this incisor down and back, and the upper incisor has moved slightly forward, which is all positive. But it has to be subtle, otherwise you're going to bring those roots through the labial plate. So then, what's happened with this just 2-ounce rubber bands is we've taken, and we have a class 3 profile and turn it into more of a class 1 profile. But I didn't want to stop at that point because I know, of course, she was now, she was 16 and a half years old at 10 months. So she still had the potential of some growing, and so I told her that I wanted to stay in. Now this is at 17 months where we were just continuing the rubber bands. Once we got to a point about 13 months, I had her go to just nights with a rubber band, but she stayed with 2-ounce rubber bands so that she could continue this pressure on the upper plus keep the lower in check. The torquing was coming out pretty good. So they were just finishing. Now this was at 17 months. It actually took me, I stayed in 22 months overall. And she was wearing this at night after 13 months. Okay, so like I said, now, when I put the brackets upside down, then what will happen is the active torque will go too far if I just left it in. So now I have some options. Once I get the incisor upright and I've got a perfect front bite, what I want to do is I want to take that active torque out of there. So how do I do that? So I've got the options. Now if I had the regular torque upside down and it's still active, then I've got to make a decision. Do I re-bracket with a low torque bracket, or do I go to a smaller wire size, or do I bend the wire? I could put some torque in there. I could put 10 degrees of torque in there and be fine. So now that's why I think it's easier for the bulk of orthodontists to use a low torque bracket and use the wire upside down And then you're fine when you go to that 1925, you don't have that active couple continuing to over-torque that tooth. Now, of course, here on this gal, what I did is I bent the wire. I put some positive torque in the front teeth, and that's how I did it. And here you go. That shows I just bent some wire on this because the bracket was upside down. But that's why I think it's easier to use the low torque bracket from the very beginning. Because what I see throughout the world is that most orthodontists don't like to put any more third order bends in than they have to, which makes sense. That's why we have variable torques. But on Asian patients, I think this is very, very important because if they're too proclined, then you have the option of putting in active torque and widening the wire. And here you see I actually increased the occlusal plane angle compared to FH in this whole treatment here as we got to 10 months. And that was very helpful. So we finished it up, like I said, in 22 months. But then I thought it was remarkable. Now this was over a year ago now, and I put her in a nighttime splint, a connected retention splint, and if we have time I'll talk about that. And she's held very nicely. But I think it's a striking change. She's turned in to be a gorgeous Korean woman. Now she's 18. So that's a striking change for just using passive self-ligation and 2-ounce rubber bands with no bone screws or no surgery, of course. You can see what happened here, but it's very positive change. And her upper lip is very beautiful. So the inclination to begin with was very, very nice. The inclination when we finished was very nice. And actually I uprighted the lower incisor, I proclined them slightly. Okay. So now let's talk about what happens with crowding and proclination and arch width. So I wanted to show you in detail another case. So passive gives me an ability to attain transverse arch development and create space while controlling the incisor proclination with light forces and early elastics. The upper lip is what I use to judge the results of this treatment. And so, as you see here, his profile is pretty much ideal. He's got a full profile and a nice vermilion display, nice curl, and he's got a good chin. So here we have pretty severe crowding. So of course we're going for optimal aesthetics and inclination, and we want to be safe periodontally and have optimal function when we finish. Now there's a lot of ways that we could do this. We have the lower crowding. We probably have 9 millimeters of crowding on the upper and probably 6 millimeters of crowding on the lower. Now, I like to recontour the points of these teeth too before I begin because I want to have it be aesthetic. And so we could put some bone screws in here. We could bring this whole thing around. We could keep the buccal segments from coming forward. We could move them back if we wanted to. And we could extract some teeth here. But what I wanted to do was just see what I could do with passive self-ligation. You can see the crowding here. I know what's going to happen. As I begin with the very light 013 copper night-tie wire, same here, as I start to make space, I know what's going to happen to those incisors. They're going to procline. Now you can see the asymmetry here as well. The upper midline is quite a ways over, and the lower, the mandible is asymmetric to the right. We have almost an ideal incisor position here, upper and lower. So I would like to maintain not only the inclination here, but the anterior-posterior direction. He's got a good airway. He's got a great profile. And here, of course, the midline is somewhere in here. So his lower's off to the right, his upper's off to the left. So what are we going to protect? Definitely I want to protect the profile. I want to keep the full lips and the vermilion curl. That's why I didn't want to extract. I want periodontal health, so I want to maintain the health around these roots. And I want to maintain the incisor axial inclination upper and lower. What I want to make better is I want to, of course, alleviate the crowding. I'd like to have a little more incisal display. I'd like him to show a little more teeth on his smile. I'd like to improve his arc of the incisal plane. And, of course, I want to correct the midlines. And I want to idealize the occlusion. And at the same time, I was hopefully going to improve his asymmetric facial view as you look from the frontal. So, what are we going to use for torques on this? What are we going to select for the variable torques? Now I know what I would select. At this time, I was still playing with it to see what I would select. But here, I know these upper teeth are going to come forward. Those rascals are going to move and they're going to procline. And so what I want to do is I want to have a low torque up on the upper anteriors. Here, these are going to want to procline as well. So I know that I would like to protect that with some low torque. So now if I were using DQ, I used MX here again, so I didn't use DQ. But I would use the low torque and the low torque here for both of that. So showing the axial inclination, the incisor is very good. So I actually started out here with low torque and low torque. But these were, of course, those hybrid brackets. And I later changed those, and I'll explain that in just a second. So I skipped this tooth. Today I would probably not connect to this tooth right away. I would just use the coil spring here, skipping this tooth, and just start subtly. And today I would start with crossbite elastics on the right side. I would use Parrot crossbite elastics. I didn't on this case. I didn't start crossbite elastics till after the 1425. And I would probably start with a little anterior cross elastic here, a light one as well. Now I know also that as these unravel and as they procline, it's going to want to open the bite. So I would probably wear a light up and down elastic as I worked with this today. So here you go. Here was the original incisor position. And so after the round wires and the 1425, I'm going to expect the anteriors to look like that. And that's pretty much what they look like at about, it was 11 months on this one by the time we got this cuspid down. So now I've got a procline situation coming, so I want to have an active torque. So today, I would use a low torque upper anterior bracket, and I would use the 1925 pre-torqued upside down Nai-Tai wire. You can see I just went to the upper bis at first with the wire, just to keep it sliding the best I could make it. I went through the lower first molars, even though I had put bonds on the upper second molars and the lower second molars as well. So here we are. And this is about, I think, 11, 12 months. And you can see, just exactly like I showed, we've got the bite opening up. I put some lingual tongue reminders down there on the lower anteriors. And now is when I started the crossbite elastics, is right after this. But you can see now, I don't have a head film, but he's protrusive here because he's proclined on both the upper and lower anteriors. So now on the first wires, we are getting a mild degree of widening here. And that varies. Sometimes I get more widening here early. Sometimes it takes a while. And on this case, we had a little more proclination than widening of the arch. If the arch widens enough, then I'm able to not have so much proclination. But I had, at this point, I had the low torque on and a low torque on. And right after this, I took these brackets off and I put regular torque upside down. Now, I would have liked to have the low torque and just use the wire because I actually over-torqued this tooth, this lateral incisor here, number 7. I over-torqued it, or brought the root too far forward. Now, at this point, I was wearing crossbite elastics. I started out with 2 ounce, and I got up to 3 ounce, and then this actually was a 4 ounce rubber band at this point. So it was a zebra rubber band here. And then I had a zebra up and over as well. So I went from the lower hooks up over the centrals to the lower hooks with both rubber bands. So that's a zebra, and this is a zebra. And then I still had him wearing a cross elastic here at night on the right side. But you can see I over-torqued that tooth. So it's much safer, I think, to use a pre-torqued wire and use the low torque bracket with a pre-torqued wire, and then you have subtle detorquing, which I think is really more ideal for all of us. But now, as I'm working with the torque here to upright it and get the root forward, get this back, then what happens is the only way that can come back is if the arch widens. So now what's happening is the arch is widening as I'm detorquing the teeth. Like I say, pre-bent Nai-Tai wires, or I've got to bend the wires, or if I've used the torque flip, once I get there, then I've got to put positive torque in that bracket so I don't bring the root too far forward. Now that's what I did on this case is I bent the wire. But here you see, right from the very start, this is a Damon arch form right there. That's the 14 by 25 arch blank put over that arch. And so you can see it was already about the size of a Damon arch size already. And these bicuspids aren't too retroclined. But then it started to develop. Of course, these teeth proclined. This is still that same arch form. But now as we work with the torque, and what happens is I would widen the wire because it can't detorque properly unless the arch widens. So now if we compare that to a 1425 Damon arch, then this is the arch that I ended up with. So as I went along, what I would do is widen it slightly, and I'll show you in a moment how I do that. So I think that's an important aspect, and Stuart Frost is going to go over that again this afternoon. And I think this is very, very critical in order to get the results we want non-extraction, is to be able to widen the arch properly. Now, it has to be done subtly, too. Otherwise, the teeth will procline. But as we did on Jose here, you can see the width that was achieved there. And it wasn't just tipping. Here is the intermediate stage showing at the end of the 1425 and how he was open and proclined. And here is the stage when about 17, 18 months as he was now getting into a fairly good arch form, good inclination. I actually, like I said, I moved this root too far forward on that upper lateral, but he's starting to look good. So now it's a matter of making sure the torque of these buccal segments is proper. And I'm going to show you how I do that. So now we went from having no room for this canine and slight crowding on the lower. We had, I think, a -6 here. We were able to get a very decent inclination of these teeth. Here shows the, for the crossbite elastics, the lingual Kaplan hooks with the tongue spurs there as well. But very good inclination of these buccal segments. Now we achieved a very nice full smile. So let's see what it did. So here's the final head fill. Here's the final profile. We've got very nice inclination of the upper incisors, very nice inclination of the lower incisors. You see the surface of the upper central incisor is perpendicular to the Frankfurt horizontal, which reflects the light the best. Now here's the beginning, and here's where we ended up. So now with all that crowding, we didn't move the incisors forward at all. So what that shows to me is that we can maintain the torque of those incisors. We just have to look at how much arch development can we get. Yeah, and here it looks like I actually uprighted those lower incisors a tiny bit. So we did protect it. We did protect the profile. We protected the periodontal health. We protected the inclination of those incisors, and we protected the AP position of the incisors. Now this shows a perpendicular from the soft tissue nasion, perpendicular to Frankfurt, coming right through that incisor. Now on Asians, oftentimes I like to have that upper incisor just slightly forward of that nasion vertical. From the soft tissue nasion through the perpendicular to Frankfurt. Often on Asians, I'll have that incisor a little bit forward of that, which I think the Asians have beautiful lips, and being a little bit more protrusive, I think is becoming more popular in Asia. You can see my lingual retainer here was coming loose. But you can see the increase in resting vermilion display there just by the nice widening of the arch, even though the incisors are in the same position anterior-posterior wise. And the midline is right on with the middle of that philtrum. And the symmetry seems to be better. But you can see the inclinations of all of those teeth. I'm very careful to try and finish these with the best inclination possible. And I think that's very, very important. And of course, Asians typically have very nicely shaped teeth. And so the torque and the inclinations become extremely important on the finishing. So you can see just with that little bit of arch development that we were able to take care of the crowding, and we didn't have any molar distalization at all. The arch depth is the same from the mesial of the molar to the lingual of the upper central is the same as when I started. So there was no molar distalization here needed. And I think that's the important thing, to see where do we want to end up with these incisors, and where do we want to end up with the transverse development so that we fill up those buccal corridors the best possible way. Now, another way of gaining space is slenderizing the teeth. Say you slenderize from second bite to second bite, but you still only gain, now I didn't do that on this. Any of these cases were not slenderized. But that's another way on Asians that you can gain that extra 1.5, 2 millimeters of space if need be. This just shows now when I got at this intermediate stage, you can see the buccal segments on this right side, they're proclined. So when I got to the final wires, then what I did, even though we have a minus 22 here on the first molar and a minus 27 on the second molar, as far as torque in the bracket, I still spun a little buccal root torque on that side to upright these teeth so that I would get the right inclination. And of course, if I get the right inclination, I know it's going to be much more stable. If I leave them proclined, I know it's going to want to collapse. The lower is more uprighting. So I hope that's helpful as you look at how you're going to work with the inclination of the anteriors as you develop the arch. So the other thing, I want to make sure that I don't inhibit the development of the arch buccally. How can I inhibit? The way I would inhibit the buccal development is if I take a stainless steel wire and keep it the same as the 1425 or the 1825 as it comes out. If I keep it the same, it's not going to develop any further. The same with a TMA wire. So if I take a 1925 on the upper, then what I want to do is not inhibit it, so I expand it slightly as I adjust it, which I'll show you. So that I think that's real key, that if you want to get some developed, that you don't inhibit it. Because I used to inhibit it many years ago when I tried to keep the arch the same, and it's pretty much been a teaching in orthodontics that you never want to expand the arch. Now Ricketts expanded the arch quite a bit, and Ricketts showed way back when that it's relatively stable to expand the buccal segments even on an adult. But for some reason, in orthodontics today, overall, they think that we can't expand it. Now, Hisham is going to talk about this tomorrow morning, but this shows a case now with about 5-6 millimeters of crowding here, but showing it on the first appointment. And what happened on this case, now these didn't flare very much because we got big development on the first arches. And so the first light wires, we were able to get good buccal movement as we had this, there's no binding to speak of in this arch, and we're getting very little proclination. So I think that's where Hisham is going to talk to us about tomorrow morning. And I just saw Hisham speak a couple of months ago, and he's showing beautiful, beautiful cases based upon his research. Okay. So here, even if you have spacing in the arch, I think letting the arch work, I've never seen a patient that didn't want as wide of arch in the molar area as possible. It always seems to look better if you do it. So working with that adaptation and making sure we're not restricting it, I think is very, very important. Now here you can see she had spacing, not much crowding, and we were still able to get a gorgeous arch form back in the back, which was very attractive. So I think it's good to test that response, and that's what I've been doing over the last years, is trying to test how much width I can develop, how much crowding I can withstand, and get the proper inclination. Not that we're going to have to extract on some teeth. I know that. On some cases we've got to extract. I just looked at one a couple of days ago, and it just didn't work out. We've got a lot of low tongue action, and it's going to have to be extracted. There's no question about it. But we know that we've got a chance on so many cases if they're not proclined too far, and if the lips are still competent. Well, this is a case I did on a 27-year-old female, and some of you have seen this case, but it just happened to be just a marvelous result because it was so crowded, and the arch really developed. So a lot of, particularly on the lower arch, it's mainly uprighting the cuspids and the buccal segments. Now, some people say that we should not expand the inner canine distance on the lower. But what I notice is that the tips of the canines on all of my cases are widened. But at the gingival margin, it's typical not to widen the intercuspid distance. Now this is a case that was done by Dick Eastham, but you can see the retroclination of all of these teeth. Now as he just went through and uprighted them, now he didn't expand this arch at all. In other words, the molars didn't hardly expand, but you can see at the gingival margin, he actually decreased the inner canine distance, even though he got in a whole nother incisor here just by uprighting the cuspids. But I do see some bodily movement, particularly on the upper arch. I see a little bodily movement possible on the lower arch, but it takes time. What I saw is when I first started using passive self-ligation, I was moving too quickly. And so I was moving through the wires too quickly, and I didn't see much expansion. But as I started to take my time, I started to see that it was taking me about 16 months to get some arch expansion that was very noticeable and that would work out through a crowded non-extraction case. So where I used to, when I first started, I was finishing the cases in about 11 to 13 months, and now, of course, it's pretty much a minimum of 16 months, and if it's a severe case, it might take me 24 months. But I think that's an important note. So seeing that bodily movement up here is possible. That's why taking the time with the arch wires is important. And Stuart and I have been doing this now for some time on getting these nice arches. And what we try to do is each time we adjust is we expand the arch about 2 millimeters on each side of the first molars. Here you can see on this 27-year-old female how crowded this was. Now this is a challenging one to do. I've seen people do this where the lower incisors are that crowded, and what happens is oftentimes we'll lose the labial bone on an incisor. But I took my time on this case, and you can't skip too many teeth when you do something like this. And look what happened here. But I didn't widen the cuspids very much at all. It's just a matter of what happened with the arch form and proper proclination. Now, on that case, I did get proclined teeth. Now, I did flip the brackets, use low torque on the lower, but it took me 6+ months to upright those teeth. So when you're uprighting teeth, you have to be careful, you have to go slowly, and on some people it takes maybe 9 months to upright the teeth as you're getting width of the arch. So not getting in a hurry, I think, is very important. And of course, as I get close, then I start to do some occlusal adjustments. You can see the articulating paper mark there. But I'm trying to make sure I keep coordinated with the lower as I do my adjustments. So here's this 27-year-old female getting down the road so where her torques and tips and everything are looking pretty good. You can see that I've adjusted the wire. This was a 1925 TMA on the lower and a 1925 steel on the upper. Probably now I would just do a 1925 steels on both, because when I'm detorquing, I would much rather detorque with a TMA than a steel. It's much better pressure. But taking the time to get those proper inclinations makes all the difference in the world aesthetically. Certainly she's not an Asian, but this all applies to the Asian population, because you're typically detorquing teeth with the Asian population, unless you're extracting and then you want to hold the torque the other way. But you can see here, all of these inclinations are set up for beauty. Now here was a 1425 arch blank put over her original arch. And you can see her original arch was already wider at the molars than the 1425 Damon arch form. Now here is where we were finishing, and you can see how wide that arch is. So as I was detorquing, I was widening the arch. There shows the difference between a 1425 Damon arch blank and the arch blank that came out of her stainless steel wire. So on a 27-year-old female, we were still able to get quite a bit of arch development, which was very positive. Now you can see that the arch depth has increased. So I've moved the anteriors forward a bit, and I've moved the molars distally a little bit. So that's what we have to do, is combine arch form, arch width, and axial inclination as we work with these cases. And make sure now that we get our buckle torques in order. Now this is showing how I'm going to widen an arch wire. So I'm taking a standard arch blank here, a stainless steel. You do the same thing with a TMA. So what I'm doing is I'm widening it a couple millimeters at the molars. But I'm widening the entire arch. I'm not just taking it from the cuspid on back. So I'm widening it. You can see I've widened it here a couple millimeters on each side at the molar. Now if you take and squeeze that back to the original size of the molars, then it comes back right to the same arch form you started out with. So we're maintaining that arch form as we develop it. That's really important. Now I just wanted to show you how as I widen it, I'm holding it there at the mesial of the first bicuspid, and then I'm putting about 10 degrees of torque at the first molar. Okay, so I'm spinning a little torque in from the first bicuspid on back. And that, as I widen it, that will help to keep that upper segment. And that's an easy bend to do. You hold it at the first bi, spin a little torque, and which is about 10 degrees, and that's what I do. And then I let that work out. I let that wire stay in there. I check them every 7 or 8 weeks, but I let that wire stay in there for quite a while. You can see it's about 10 degrees. My hand is very steady there, don't you think? Now these wires were taken out of a patient. Now that's what happens when you try to adjust one arch at a time. So then you wonder why the arches don't fit together, because you see the upper arch is much wider than the lower arch. So whenever I adjust, I always take both arch wires out so that I can coordinate them perfectly. Now if I need a little extra width on the upper, I can do it, but this will never fit together. You'll see, you wonder why the cuspids and bicuspids aren't matching, because that's what happens when you try to adjust one arch at a time, and it just doesn't work for me. Now I like to put hooks mesial to the cuspid, and then it's easier for me to coordinate and adjust, and you never lose your way. I don't have to mark the midline. So if I use hooks on every working wire, which I do, then it's easier for me. But that shows a nicely coordinated arch right there. Now that's what we want to do. We want to bring it in a little at the second molars, actually a little more on the lower than the upper. And that's the way I coordinate an arch. And I think that's extremely important in what we want to do. Okay, and what I saw is I saw an advertisement that was talking about if you have smaller anterior teeth, then we should use a smaller arch form. And the reasoning behind this was that we wanted to create a golden proportionality as we moved back from the central onto the bicuspids. So this is a standard 1425, this pink, and the blue is 16% reduction of that arch, so that this would be a narrower situation, so that you would get proportionally a golden proportion from the central on back. So it's gradating those teeth. The problem with that is when you go to a 16% reduction, you're going to narrow the molars. What we don't want to do, what I don't want to do, is narrow the molars. Now, I think it's important to remember what is important aesthetically when you prioritize looking at a smile. First of all, the smile arc is extremely important. So it's that arc that the incisal edges follow that lower lip. That is extremely important. The buccal corridors are very important to the appearance of a case. So I don't want to narrow those buccal corridors if possible. Of course, alignment of the teeth and the torque inclinations like we just talked about, and the incisal display from the upper lip and the vermilion display, all of those are extremely important to the smile. If you'll notice, this case does not have a golden proportionality as it grades back from the centrals and the laterals and the cuspids. The cuspids are actually wider than the laterals. But what I've found and what researchers have found is that gradation of tooth size is much less important for the smile than the smile arc and the buccal corridors. It's a minor contributor. You'll look, and I'll show you 50% of my cases do not have a perfect gradation of golden proportionality as you look at them, but most of them will look beautiful because you don't notice that. It's just not a decisive factor. Now here's a case that Dwight did, and I wanted to use it because he did such a beautiful job. And here's a case with very small teeth. And here, of course, when she's finished, showing that there isn't a golden proportion to that gradation of those. Now here is a standard arch blank, and when you look at this, he's widened. Of course, what he did was he opened for a third bicuspid, upper and lower, because her teeth were so small that she was concave here in the profile. And so he wanted to bring the teeth forward, which he did, but he widened them at the same time. And he actually helped her profile. But I think notable here is that he got a very wide arch form back in the molars, which I think looks much better with the smaller teeth. So why use a narrow arch form when there's overwhelming evidence that it's much more aesthetic to develop the arch in the back? Therefore, if you use this 16% reduction, you'd have a narrow arch in the back, which I think detracts even more with narrow front teeth. So I would expect more of this type of an arch form with a narrow arch, and we're actually working on this at Ormco with Aaron. You'll see Aaron Goodall today. He's over from the Orange County, but he's a product manager of the Damon over there. And trying to work with a wider arch form in the molar area and maybe just a slight bit more narrow in the anterior, which I think is positive for narrow teeth. Now, they say, people advocating this narrow arch form say that if you put a standard arch blank in with narrow teeth, then you're going to get spacing, because it's going to widen the arch, and then of course you'll have spacing between the anterior teeth. But what I do as soon as I get to the 1425, I put a C-chain from cuspid to cuspid with the 1425, and so I consolidate the space, and so it doesn't space when I'm moving up through the wires. So I consolidate it, starting with the 1425, just a C-chain lightly from the cuspid to cuspid. And so I adjust the stainless steel, or TMA, narrowing the canine to canine slightly and widening the molars. I think that has a tendency to look much better. Now this is from the Damon arch form. This is 4 millimeter expansion on each side of the first molar. So as we look at our cases, this was a little gal that was a teenager, but working with these principles and trying to get the smile arc right. Now she works for us in Reno at the clinic. But looking at the smile arc, the buccal corridors, the tooth alignment, the torque and inclination of these teeth, the incisor display and vermilion display, and trying to keep the lips and vermilion full, so that that's what the ladies want. Is in America they're having more lip injections today than ever before. So that's what we're trying to do, is keep them full. And when they have a narrow arch, even though they have a beautiful profile, still trying to expand those buccal corridors and work with them in the way we just talked about. What happens in the adult that's really narrow? It's a slower process in adults. We still have to make sure we adjust the proper buccal inclination in the arch as the arch increases in width. And this was a very meaningful patient to me, because I had treatment planned him for surgery. He was a professor of math. He was a math professor at the University of Nevada. He had a great insurance plan to cover the surgery. And the problem is right as we were starting, he lost his job because they were cutting employees, and so then he didn't have his insurance. So then that gave me an opportunity to see what I could do with just passive self-ligation alone, and so I felt that I would just do it with passive self-ligation alone and try to do it that way, rather than take the bone screws and intrude his upper molars to see what kind of result we'd get. So you can see how narrow he is, and crossbite, crowding, a little bit of an anterior open bite, of course. He's pretty dolichofacial, long lower face height, and so he said, let's just do it the best we possibly can without the surgery. So this is Rungzi's drawings again. So what I did, I went to the light elastics right from the very first moment. And so I put Parrott's crossbite elastics, I put Parrott's class 3 elastics, and I went down and under on the anterior, what we've come to call a reverse rainbow here. So this is the rubber bands that he wore. And he had lost his job, so he didn't have to worry about wearing rubber bands. But he did wear them all the time. Now this is where he was, and this is about 11 months. So we were just working through the wires and finally got to our working wires. And he started to close down on his bite fairly good. He still had a cross bite on the right side. We're still fighting that. and he wasn't completely leveled at this point. We had placed the brackets more gingivally on the lower anteriors, of course, and fairly gingivally on the upper anteriors to combat that open bite. You can see what happened here as we widened out the upper. We had proclination of the buccal segments and the cuspids. But by the time we finished, we had an ideal situation as far as inclination of those segments. So from the very beginning, we were a little bit retroclined, then we became proclined, and then as I worked with the wires the same way, so I put some buccal root torque in the segments with the 1925 wire and just let it work. And I used the crossbite elastics to keep going. But it took me 9 months. After I got the teeth to this point, it took me 9 months to upright those teeth and subtly do it. And I just used a 1925, and as you can see, this is a TMA. It's a 1925 TMA, very subtle. So here you go, and of course afterwards, I gave him fixed retainers on the inside of his upper and lower anterior teeth, and then I had him wear that retention splint for at nights. And he turned out really good. This upper second molar on the right never did fall into place, but he was finished, and it was 27 months, and he said, sayonara. And so he said, that's all. And that's when we finished. But look at this. Now, this yellow line here goes from the buccal plate to the buccal plate. If you can see that, it goes from the buccal plate to the buccal plate. And look what happened to that same line. This is size corrected. Look at what happened to that buccal plate. Now, we certainly don't take away from people using rapid palatal expansion or soft expansion from the palate, because I know a lot of people still do that. But this is just using elastics and torquing the wire, and of course using the buccal root torque. But look at what happened to that alveolar process here, and the change that occurred in the molar in terms of width, but the alveolus has adapted to that. And I think that's very, very important to see, because nobody wants to show that, because it's being criticized by the Kokiches and all of these people around the world. But that's real stuff, and I think it's real beautiful to see it. And I would much rather have this than have that surgically corrected by widening it, if that were possible to do, even though it took some rubber band wear to do it. But it was all light rubber bands. It wasn't heavy rubber bands. And so I think doing this subtly is very, very important to the work we do. So we're not only getting tipping of the bicuspids and molars, but we're also getting bodily movement, and that alveolus is adapting. Now you can see right here at this cuspid, he had a torus on his cuspids, and so we had plenty of bone there. But I think that's notable, and it's something that as we show this, it gives us hope that there's possibility that we can do much more than we thought we could do with this passive self-ligation. We pretty much addressed arch development, buccal torque control with arch width. We talked about incisor control and torquing the incisors. We didn't get much molar distalization in these cases. We didn't need it. We also talked about the shape of the wire. So I think with that, we've got another hour to go here, but why don't we take a break at this time? Would that be adequate time to take the break? We okay? All right, let's take about a 35-minute break. Thank you very much. We talked a little bit about early elastics this morning, and early elastics to me has transformed my practice, and it's made an unbelievable difference because for some reason, the 2-ounce rubber bands from the very first day of treatment. Now I have braces on myself, and I had a deep overbite. And I'd worn down my lower incisors so that I'd worn them down at least 2 millimeters. So I had them built up with composite, and then I had actually Stuart Frost put them on for me. And we put the bite turbos behind the upper central incisors. And I think the important thing with bite turbos, when you disarticulate teeth, I don't like to disarticulate more than about 1.5 millimeters of posterior teeth. So I put them so I have to add to them the next time. But that makes it much more comfortable, and then the posterior teeth start to touch within about 6-7 weeks if you only open them about 1 millimeter to 1.5 millimeters. But one thing that I've tested over and over again is how much time you have to wear the early 2-ounce rubber bands. And for sure, the only way I get remarkable results is if they wear them day and night, full time. And I tell them, of course, on an anterior rubber band, if you're wearing a Parrot rubber band on the anterior, it's a very thin rubber band and you can hardly see it. But the one nice thing about early elastics with 2-ounce is when I wore them, I could not feel the pressure. So my teeth were not sore. So when I put the bite turbos on, just opened 1.5 millimeters in the posterior, then I wore the early rubber bands because it was a deep overbite from lower first molar to upper first bicuspid. So it's a little class 2 direction. And I never felt a thing. And I was touching posterior teeth again within about 6 weeks. Then the next time I just add a little more to them. Same thing. And then another 6 weeks but I never felt any discomfort. My teeth have not been sore from the moment I put the braces on, or Stuart put them on. And now I just changed them, the wires last week. I've got an upper 1925 TMA, and I've got a lower 1825. Now I never changed the wires for about 6 months because I didn't take the time to do it. But it's still working, it's very effective, and it's almost finished, even though I've only had a few wires in. So this early rubber band thing, I think, is very, very critical. Where I see people, I think, go astray and get off base with it is when they use too heavy of rubber bands. Because as orthodontists, we're pretty impatient. And so if we don't see the results happening very quickly, then we get, well, maybe I should move to a heavier rubber band. But I see that if I just stay light, for instance, this gal had TMJ problems, and she had an anterior open bite, slight class 3. She was touching edge to edge, as you can see here, touching edge to edge, and little crowding. So I know in her first wires, now this is going to get more class 3 because with that crowding, it's going to procline a little bit. And now I'm going to be more class 3. So what I did with her is I put some posterior bite buttons on. And what I've started to do with posterior bite buttons, instead of just putting them on a cusp, I put them in the fossa because it's more comfortable. They have more room to glide side to side if you put it in the fossa rather than on a cusp, which can cause an interference. So I put her braces on right here, and you can see the posterior just filled up the fossa and opened her bite slight amount. And I put this reverse rainbow rubber band from the upper laterals down around the lower centrals. Now this was an MX bracket, so I could go around the wings. Now with the Q bracket, the wings aren't big enough, so you have to put the little hooks in order for that to work. But anyway, so it opened her bite, and I wore this, even though she was a little class 3, this has a little bit of a class 3 vector. If you come from a top underneath the lower centrals, and it has a little bit of a class 3 vector. So I just had her wear this full time, and then I got her back in 6 weeks. Now I saw her in 6 weeks because I was headed for the World Federation meeting in Australia last January, and so I wanted to get her back right before that to see how she was doing, because I was going to be gone for about 3 weeks. So here she is from the side. You can see I ended the 0-4 wires at the bicuspid. You can see there the little class 3 relationship on the side view here. Now, this is 6 weeks. Now that's just now she's a pharmacist, and so she's in front of people every day. But I told her, I said, you have to wear that rubber band full time, 24 hours a day, work, home, everything but eating. So that's what she did. Now in 6 weeks, this is where she came. Now that's pretty amazing for 6 weeks, and she didn't even feel the pressure. She couldn't even feel the rubber band because it's just 2 ounces. It's pretty special. And so at this time, I started taking down the bite turbos because we didn't need them anymore. Pretty amazing. In 6 weeks. So then I let her go, and I went to Australia, and then I didn't see her for another 11 weeks. She kept wearing the rubber band, and now these teeth were touching these brackets. So it's pretty effective, even at 2 ounces, and people think we need stronger rubber bands. On a class 2 or a deep bite, like I have, just to review that, the way we put the bite buttons on is we use Pink Triad and the little mini mold kit that you get from OrthoArch, and we just have 2 of these preloaded. And then as we put the braces on, we prep the linguals at the same time. So before I even come to the chair to put the braces on, my staff puts these on, and then after I get the braces on, I adjust them so that I'm just open 1.5 millimeters in the posterior region, and we're touching both sides. Now, if indeed we have too much overjet when we open the bite, usually if we just open it 1.5 millimeters, we don't have the worry of biting behind. But I don't want to make them too long, so if necessary, I put them on the cuspids. Now, if I put them on the cuspids, that's a nice way. It still works fine. We want to keep them as far forward as possible so we get the most eruption of the posterior teeth. But once we get to a point where I can put them on the centrals, then I usually leave them on the cuspids and put them on the centrals too. So now we have a little tripodized situation, which makes it real comfortable. But I typically just do the centrals unless I do the cuspids, and later I do the centrals too. So I just get this Triad and actually Stuart uses a Triad gel. So you can either get the rope or you can get the gel. It doesn't matter. But the nice thing about Triad is it's a soft material and it won't wear down the opposing teeth. If you use a hard composite up here, or even metal, it has a tendency to wear off the lower incisors. So that's why the Pink Triad is nice. And the pink is easy to see when you're taking them off. And so they're easy to take off that way and see them. So here you see, this is the second appointment, and you can see we're opening things up. The nice thing about using bite buttons instead of using reverse curve wires If you use reverse curve wires, you intrude the upper teeth too. And on most Division II cases, you don't want to intrude the upper teeth because they usually have a beautiful smile line. And so by doing it this way, then we're extruding posterior teeth. So by extruding the posterior teeth, we're opening the vertical, but we're able to maintain that beautiful incisal display. And then so you just, if some people still use a reverse curve on the lower, I don't like to use reverse curve wires because it has a tendency to procline the lower incisors more than you need to. So I just use the flat wires and let the posterior teeth extrude, and then that levels it, and usually by the second appointment, like this, it's leveled. Now, when they come back for that first time, I add a little more to the bite turbos so that then I can keep working in this direction. And it's a beautiful way to create a nice result with a Division II. I didn't used to like to deal with Division IIs because I was intruding the bottom teeth and the top teeth, and I was flattening out their arc, and so this way I get a much more pleasing smile. But there again, I only use quails. So until I get to the 1825, I use quails. Now the only time I have to go heavier, rubber bands, is when they're not wearing them full time. So if they're not wearing them 24 hours a day, then I've got to go up to the 3 ounce, then the 4 ounce. When I get to the 4 ounce, I like to have hooks here to hook it on the wire. So I'm dispersing the force clear on the wire, not on individual teeth. So here it shows from the lower first molar to the upper first bi. Now on these MX brackets, like I say, you could go over the wings, but now with the DQ, you can't go over the wings. You have to stick in a hook. But the drop-in hooks are very good. You just have to, sometimes when we're too close to the gingival there, I'll put the hook in first before I put the bracket on. The nice thing about the drop-in hooks, and I found it on myself, is that there's only one place you can hook the rubber band, because people get mixed up where they're supposed to hook them. And so with the hook in there just on one tooth, it's easy to hook it and get it in the right spot every time. But you can see I'm just opening up a millimeter or a little bit more on the posterior there. This being the second appointment, I think we're up to 1425s here. So this shows the progress, and this is from Rung Z. This is from John Lin's book, by the way. And John Lin's book is a Bible, so we need to all have his book. But anyway, this shows the progress so that we start from the quails, the lower first molar to the upper first bi, and then we go to the 018. This is the first wire, 014. Then 018, round wire, copper nitite, keep the rubber bands, quails, and then we get to the 1425. Now we can move up if we have to, but I usually don't have to if they're wearing them all the time. If they're not wearing them all the time, then we have to move up to a 3 and a 4 ounce rubber band. And then 1825 for about 7 weeks or so. Then we get to the 1925 and we're totally leveled. And that's why I bracket on a deep bite case. I put the lower anterior brackets quite incisively because I over-correct for a reverse curve of SPE, if you know what I mean. And that way I'm over-leveled, and that allows me room for a nice smile arc here. And I like to over-correct, actually. So that's when I use that kangaroo. I'll add to the bite turbos if necessary, and then over-correct to edge. On a deep bite, I take them edge to edge in the front, and then I'll hold them there for 3 months. So I'll lighten up the rubber bands and hold them class 2 with edge to edge, or toward class 3. And then I just subtly bring them back, but I'm still wearing 2 ounce class 2 elastics. That allows them to jump it back, but if I take away the class 2 elastics, they go too far. They bounce back too far. Okay, because as you're wearing these rubber bands, it tips the occlusal plane, and the occlusal plane has a tendency to upright, which relapses to class 2. So I think that's very, very important. So here shows it overcorrected, edge to edge. See that? That's overcorrected. So now I've overcorrected this because I know a deep bite is going to relapse. That's the biggest relapse item we have. If we treat a deep bite and we don't retain it properly and we don't overcorrect it, it's going to be a deep bite before you see them in a couple of years. So you can see how high these lower anteriors are bracketed. I've overcorrected the curve of Spee. I will recontour these lower cuspids and first bi. I will recontour those as I finish. So then I still keep the light rubber bands and I bring them. But what I noticed on this lady here, who works for me actually, see how she's perfect class 1 on the cuspid? On both sides she's perfect class 1. But she's hitting edge to edge in her front teeth. So what does that mean? That means I've got too much tooth material downstairs, so I've got to slenderize between the teeth on the lower. Does that make sense? So I can keep her perfectly class 1 on the side. Okay, now you see I've got good torque control here. But with those early elastics, you don't lose torque control very, very readily. So when we get to the heavier rubber bands, I like to have a hook mesial to the cuspid. So I'm working that, and that's where I like to overcorrect from that position. Thank you, Rungzi, for these beautiful illustrations. He's one of the best artists I know. Oh, when we get to this point, now if they're still not overcorrected, they're still a little class 2. What I do is I run my rubber band from the lower first molar to the upper hook, but I cut the wire behind the first molar. So make sure you remember to do that on a class 2 because this is a big anchor, the second molar. So typically on these, I want to move the lower a little bit forward and go edge to edge. So that's why I cut the wire distal to the first molar. This is all in John Lynn's book, by the way, too. Just showing now finishing, trying to get this bite socked in, using finishing elastics, and I'm adjusting the bite. See this first, or the second molar there. See the second molar, how it's open? That means to me that that lingual cusp is touching the lower. So I'm not getting a good buccal occlusion. So then what I do is I take articulating paper and I'll go adjust the lingual cusp on that upper and maybe a little bit on the lower, and then keep wearing the rubber bands until that's socked in. But you can see now, the way we did this, I maintained a beautiful smile here with her deep bite, and so I didn't intrude the upper anteriors. This is just a case that we did at University of Pacific. I've been an associate clinical professor at University of Pacific now at the orthodontic department for about 12, 13 years. And this is a gal that came in, and she was a full class 2, division 2, and she had a nice smile line, and the student, which was Dr. Degoni's grandson, Brian Degoni, and if you know Dr. Degoni, he was dean at University of Pacific School of Dentistry. He's been president of the AAO, and but his grandson is a real good orthodontist. So he wanted to do this with it's a full class 2, but instead of using a Herbst type appliance, which we usually would, he wanted to do this with the passive self-ligation and just rubber bands. So that's what we set out to do. And here you see the full class 2. That's a difficult case to do with just elastics alone. But she had a good enough chin that we felt that it was certainly worth a go. Now, even had some third molars here, huh? It was done the same way with putting some bite turbos behind the upper incisors and then beginning with the 2-ounce quails. And then once we got to 1425, we actually went to 3-ounce rabbits. So they're 3/16, 3-ounce rubber bands. But this gal did a pretty good job in wearing them full time. So now you can see we're protecting her smile as we're erupting her posterior teeth in the right direction. And she's got a beautiful upper lip. And so here we actually had corrected her in about 18 months. But we're still going for a little overcorrection because there will be a rebound. Now we've got a little proclination of the lower anteriors, but the inclination of the lower anteriors is not as important as making sure that the roots are in the bone, that the roots aren't forward, and that's the key to the success of that. So 18 months, we're getting close to overcorrecting. And she let down with the rubber bands for a little while, but then she got back with it. But we were able to have a beautiful profile in this correction. And of course, we got low torque. We have low torque on the lower anteriors. So to keep them from proclining, to keep some upright pressure on them, showing the width increase, which does help the teeth from proclining too much. So we've got good enamel display, we've got good smile arc, and a good profile. The upper lip is nicely done. So here again, we just did that. We got to the kangaroos early on her. We went to those of the 1425, but we stayed here with the first bicuspid to the first molar until we got to the 1925 stainless steel. And we at first just went to a lower 1625 steel and then later changed it to a 1725 TMA. So I think the earlier rubber bands have been a wonderful addition, but you have to make sure that you stay light when you use those rubber bands, and we overcorrect and hold the overcorrection on a class 2 or a deep bite for 3 months at least. Okay, so now looking at traditional mechanics using tie brackets, we kind of did things in a sequence. So we'd get leveling and aligning, and we'd get overbite correction, then we'd either get transverse expansion first, or we'd get them later, and then we'd work on AP correction with heavy rubber bands or springs, and or then we'd do space closure, and then we'd do finishing. So kind of one step was completed before we went to the next step. And with the passive, what we're doing is we're pretty much starting to do everything right at the beginning, particularly if we use bite turbos and early elastics. So not only are we aligning with the first wires, but we're starting to level with the bite turbos and the early elastics, and we're also working on anterior-posterior correction. And with the bracket placement we're doing, we're getting the smile arc in order, and so we're also beginning transverse arch development, so that by the time we're down through the 1425, we pretty well know where we stand. And now to finish the case, we do our Panorex and the repo, and so it's pretty simultaneous to get to that fourth appointment or through the 1425. I think treatment planning for aesthetics and the upper incisor is very, very important. And that Panorex repo appointment, I think, becomes extremely important to all of us. Now, when I get through the 1425 copper NiTi, that's when I look to see what the smile arc is doing. I have them stand up so I can evaluate the symmetry and I look at what teeth I want to rebond at that point. And of course I look at the root parallelism through the x-ray. But I don't very often have to rebond bicuspids or molars because I'm very good at putting those on. Where I do have to rebond, though, is the anterior teeth, because with the differences of morphology and if it was crowded, so that's where I really change it. And at this point, you already have the intermediate stage, so you know what proclination you have at the 1425, so you know if you want to do some torques as well. So it's a great time to reevaluate. But I think our treatment plans are beginning to get different now. And my smile and facial aesthetics are improving each year without surgery. And we're using lighter elastics than what I used to. I used to start with the 2-ounce rubber bands, but then I would move up to the 3 and 4 ounces quite quickly. And now I find that staying with the lighter rubber bands, if it's not improving, then I know they're not wearing them full time. When we get to our adjustable wires, the 1925 stainless steel or TMA, or the 1725 or 1925 TMA on the lower, that's when I like to have at least 6+ months to work with that, so that I've got plenty of time to do my finishing and adjusting whatever I need. So why we call it the 654 is we've got 6 strategies from the start. One is to have a good treatment plan. The other is to recontour. I recontour the cuspids and other teeth before I put the braces on. I have good torque selection, as good as possible. I have great bracket placement, and I disarticulate where I need to, either anterior or posterior, and then I have those early elastics. So we've got the 6 things, and as a result, 5 things should be happening. I get good alignment leveling, AP correction, smile arc creation, and transverse arch development. And so with that, then at the 4th appointment, I'm ready for that Pano Repo. I've got the finishing becomes easy if they wear the rubber bands. And if I've got good bracket placement and torque selection, all of this stuff, then my finishing becomes easy. So this Pano Repo appointment early in stage 2, I think, is very, very important. So I always leave an hour for that appointment, which is usually about the 4th appointment, unless it's a complicated case. I may not get to the 1425 till 10 months on a complicated, very crowded case. But that's a critical read and react point. And see the progress assessment. I heard a very nice pearl the other day at a meeting that when they're not wearing the rubber bands and you don't notice any improvement, and you've already targeted, say you've targeted 20 months of treatment, so then you know that that's going to be, what's it going to be? It's going to be winter of 2012. So say it's December 2012. So now you go, with the patient watching, you go in and change the target date 2 more months. If they haven't been wearing the rubber bands, they see now that already they've added 2 months of treatment. And so that's pretty motivating, I think, to keep wearing these light rubber bands all the time. And I think having the patient stand up so you can look at them head on, I think it's really important to do that. And that way you can really see if one canine is higher than the other. So that way you can evaluate them before you sit them down to take some braces off and rebond them. Okay, so that's the intermediate stages, the Panorex Repo. And then it's 6 to finish from that point. Upper on those front teeth. So, and I'm going to be doing some arch wire adjustments in my finishing. I'm going to have first order and second order bends for sure. But I don't like to adjust very much, so I'd rather reposition brackets as accurately as possible on that Panorex repo, so I have as few arch wire adjustments as possible. I might need to, on the overcorrection, I may have to add to my bite turbos, 5 anterior bite turbos. So I'm looking at arch wire adjustments at torque, tip, width. I'm not going to get too concerned about the proclination of the anteriors until I start getting enough width. But I'm going to want some active torque in the anteriors like we talked about. So at this point, I still may have a reversed or a pre-torqued wire, either right side up or upside down. Of course, once I overcorrect, then I start to look at getting the idealization of the anterior teeth. I can slenderize in between the lower teeth if I've got too much tooth structure, or I can slenderize the upper a little bit, but then I'm looking at articulating paper at this point. So every appointment that I adjust the wires, I also adjust the occlusion. Because if my lingual cusps are touching or interfering, then I want to make sure I'm recontouring the teeth with a high speed. And of course, then the very final thing is finishing elastics so I can make it ideal. Now, I may keep those bite turbos on clear till this stage. So anterior bite turbos, I don't want to remove them very soon. I want to keep those till the very end of treatment because that's the way I can control this anterior bite. I've been in many practices where they're always fighting a deep bite. I never fight a deep bite because I can control it with the little bite buttons behind the upper anterior teeth. And I've still got my bite buttons right now, even though my bite is very shallow. But as you wear rubber bands, it's going to want to deepen the bite in the front. So that's why we can control it very easily. And of course, like I said, the tooth size, I may strip or slenderize between the anterior teeth, upper and lower. And of course, if I've got some dark triangles, lack of papilla, then I'll flatten the contact and maybe bring the roots together, that sort of thing in the finishing. And then of course, when I'm ready to take them off, I'm going to put the lingual. I don't like to use tooth positioners myself. So I like to finish everything as perfectly as possible with the appliances on. So when I take them off, I don't have to worry about settling. And so I have very little settling in my treatment because I've learned to control the details of that. And then I can recontour the edges of the teeth and make sure that I get them as perfect as possible with the embrasures, etc. I think we've had a lot of technological changes that are pretty exciting. I see SureSmile Orometrics has become pretty popular over there. OrthoCAD is also popular. It's does indirect bonding and they use scanners. Insignia is becoming more and more popular. In fact, I've been working with Insignia now for the last year, and I think it's becoming very, very accurate as far as positioning brackets, and I'm pretty excited. I've got 12, 13 cases going right now at the clinic in Anaheim, and so I think intraoral scanners, they're becoming very, very accurate. They're coming down in price, so maybe we'll get rid of those impressions eventually. The digital clear aligner setups, of course, that's progressing along, even though I don't use too many clear aligners. That's progressed quite, and the measuring device that Hisham Badawi uses up there. So we've had a lot of technological advances in orthodontics. I think one thing I noticed, though, technology alone, I've never seen it get me to the finish without being a real good orthodontist, and a real good orthodontist that knows how to get out of trouble if I need to bend some wires or redo some brackets. And so I see people relying on these things to do all the work and never bend a wire. And I think there's a distinction between not only using technology, which is good, but also artistic and the mechanical skills to go along with it. So the best technology without discipline of application is usually you don't get that great a result. Now this is a patient that came over to my office, and she went to this SureSmile orthodontist, and SureSmile is a product out of Texas that when you get your braces on, you scan it and you send it in, and they pre-bend the wire. The robot digitally bends the wire in all planes of space and sends it back. And so unfortunately what they've done is they're promising people in the United States that they will finish the case in 9 to 11 months. And of course I hate to promise a person I'll finish in 9 to 11 months because you never know what you're going to run into. But this person now was about 15 months in treatment, and they've been fighting some space, and you can see that there's an issue with the transverse incisal plane. The upper lateral is there. There's a big space behind this cuspid right over here, but you can see the bend in that arch wire. Now they had this chain, this C chain that they'd been working on trying to close that space for a few months, she said, but she was a little disenchanted. There you can see the space distal to the upper left canine, but there's no way that's going to close with that big bend in the arch wire, I don't think. So anyway, she was disenchanted, and she got married to one of my patients. And so she wanted me to finish it. So anyway, I just wanted to show you that, you know, just within a few months I had the case shaped up because I was able to position the brackets in a good position, even though I did have some minor bends in the wire. Now this is 10 months later. So we went through and got through the finishing wires. You can see I asymmetrically bonded this lower because she had that transverse plane issue. So I actually put the brackets a little higher on this cuspid than this cuspid and worked that so I could flatten out that plane and do it. Of course, I wouldn't want to leave it there very long because now I'd have the other problem. But I was able to get this finished quite nicely, and here 11 months I'm ready to take them off. But you can see the difference. So relying totally on technology didn't help. I'm sure it would have helped if they'd had better bracket placement to begin with. And then the SureSmile technology would work. But of course it's expensive technology, so I just, here was another one that came in from another practitioner that had SureSmiles on, and she'd come in for 21 months, and this was in complete buccal crossbite, the lower right second molar. Now this has been, she'd been promised 9 to 11 months. Now this is crossbite. The lower right first molar was leaned way lingually. And of course you can see the class 2 situation here. It's just a matter of the technology is good, but we've got to be good at orthodontics too. We've got to be able to make decisions so that we can bend the wire as we need to or whatever we need to do. So anyway, what happened is my son Arnie saw this patient and called the orthodontist and said, you know, what we would do if this happened in our practice, we would re-bracket the teeth and then start again and try to get this balanced out, use some rubber bands, correct the crossbite, maybe put on a little bite button so he could
get that adjusted there. But, so they went back to their orthodontist. Then they came back in 33 months now, where you can see it's exacerbated and gotten worse. This is still in crossbite, and of course this is more class 2. It's more open here. So it's just a matter of, the technology is good, but let's as we study this and get working with it, then, yeah, that was 22 months, that was 32 months. So that's just a shame, because it's just a matter of not being able to artistically handle that device. So we still get to play orthodontist. So treatment planning, I like to treatment plan around the maxillary incisors to see where that upper lip is going to be and see how I can achieve keeping the upper incisors where I want to. That's why on the class 2 treatment, I always try to not disalize the upper teeth very much. I want to get as much reaction of the adjustment of the lower arch to the upper so that it always looks better, because if you retract the upper teeth too much, it never looks natural. Now, another thing I see happening as we get down to finishing our cases, what I see is a lot of times upper front teeth are too proclined. And so I really watch that so I don't get too much proclination of the upper anteriors. So what I do is, if I do have a high torque situation, say I've got a class 2 or an extraction case, and the high torque has held it as I've closed it, worked it out, but then with function, and it still wants to keep torquing. So that's when I either go to a bend in the wire the other way, or I go to a smaller wire so I don't over procline those teeth. So I think it never looks natural if we over torque the upper front teeth. So having those vertical to the floor, I think is really important to the aesthetics. And so that's why we worked so hard at that this morning as we were talking about that. Here's a case that was finished orthodontically, and of course she'd been out of treatment for about a year and a half, but you can see that her anteriors are too proclined and they don't look natural. It also flattens off the smile, and so she just was not happy, and it probably got worse because she didn't wear retainers. But anyway, here you can see the inclination of the upper incisors, and she was missing that lower molar. So I just retreated it, put low torque on the upper anteriors, and did what we did this morning, and just work with the inclination of the upper anteriors, and use some light rubber bands so I could get those upright. And it just makes such a difference. And so I would encourage you to really watch the torque of those upper anteriors and be careful. Once you get finishing the case, if it takes you a while, those sometimes can torque too much and procline. Here's a case, and it was finished orthodontically, and she was unhappy about it, and the orthodontist couldn't understand it, but these teeth are too proclined. So he needed to upright those teeth. They're too proclined. The anteriors. Okay, we've already talked about that. Okay, so overcorrection, go edge to edge, and I hold the deep bites and class 2s for at least 3 months, edge to edge. And then I still wear, and then I'll start doing some up and, or down and under rubber bands on the sides, but I'll still wear some light class 2s at night so it doesn't relapse too much. On the open bites, I want to hold those for at least 6 months. So an open bite, when I'm finishing and I go to a nighttime elastic, I want to make sure I stay in there for quite a while, overcorrect it, go to a deeper bite, and really watch the occlusion and the torquing. And then oftentimes on an open bite, I'll leave the little tongue reminders on the lower anteriors, lingual, and then I'll go to a retention splint that they wear. So, but they keep those, and I'll just work the retention splint over the lower anteriors. Okay, so don't be afraid to pick up the handpiece. Once I get to this situation here, that's when I start, I've worked with the torque here, and I get to the final. So I'm proclined here, get to the final, then I've got to start adjusting the bite, as well as using the finishing elastics. So I have 2 pieces of articulating paper and holders and a high-speed handpiece with a football diamond, and I'm adjusting. Every time I adjust the wires, I adjust their bite too. So I make sure that I'm socking in and getting a good buccal occlusion as well as a lingual occlusion. So I try to treat to a centric relation occlusion. So I use a Dawson technique of holding the jaw while my assistant holds the articulating paper, and I want to make sure that we don't have a slide in centric occlusion. I see a lot of restorative dentists now say that we should have a little deeper bite in the anterior teeth and have a little room there. I treat all deep bites to a shallow bite. The main thing is I have minimal anterior contact. When they're in centric relation, I want to be able to get that shim stock cellophane through without them banging the front teeth. And I think if I do that and put them in that splint, then they seem to hold really well and very healthy. The time I get into problems is when they're banging those anteriors. And so if I keep good centric stops in the posterior region, then I have a shallow overbite with no contact quite in centric relation. Then then I can have a mutually protected occlusion, and I don't have to treat to a deep bite. And some people say in order to get a good smile arc, you have to have a deeper bite. But I just compensate with that on the lower, so I don't have to go to a deeper bite. So like I said, I prefer not to use a tooth positioner. I want to completely finish it with fixed appliances. And I think that this appliance really affords me the possibility of doing that every time. As far as retention is concerned, I use fixed retention on the upper 4 anterior lingual, and then I use fixed anteriors from lower cuspid to cuspid. I can sometimes if the bite is deeper on an open bite to begin with, then I won't go to a wire behind there because I don't have room for it. So then I'll just go to the splint. As far as I typically use an 027 round TMA wire for the lower, but you can use anything. I see all types of wires being used. You can bond all of them. I just usually bond the cuspids. But I think that fixed lifetime retention is very necessary. I've quit using that Orthoflex Tech, and I use that other solid Hilgers wire. Now they've improved that. Stu Frost is the one that turned me onto that. But I think retention for life is what I use, and I've always used it. And I see even kids that I treated now are grandparents coming back, and I see a lot of people still using their retainers and have beautiful teeth. So as far as, let me just get down to the retention splint. I'll go over that a little bit, and then we can break and have Dr. Kim. As far as the retention splint, AOA now sells the material it's the dual hardness material. So when you finish it, it's soft liner on the inside and it's a hard plastic on the outside, and they're connected together, and it's a very good material. I do not like to extend the splint like this. I like to only go to the enamel. I don't cover tissue at all. And with that, it's so easy to do this soft material now, the dual hardness material. When you take the wax bites, you don't want to cover the front teeth because you want to see where the midline is, and you also want to see that how far the lower is forward in relation to the upper. Now, if you've had a pretty good class 2, then you want to hold the lower anterior teeth slightly in front of the upper anterior teeth, and you typically have about 6 millimeters opening here. So you've got to keep your wax bite, which is 6 millimeters thick. I take a full sheet of pink wax and just keep folding it, and then that way you've got to end this at the cuspid so you can see all the anterior teeth, and you practice with them before it's taken. But this splint with the dual hardness now is so comfortable that I'd like to put every patient in it if I could. Here's one that we make in the office. Like I say, AOA is a lab in Wisconsin, but they are selling the material now, and we can do it in the office, and it's easy to do. And I don't have to block out the undercuts nearly as much with that dual hardness. You don't want them to fit tightly. I'm excited with Dr. Dischinger, Billy, and Terry. Now they're having that little advanced sync Herbst connecting a lower to an upper, so it's a nice appliance that you don't have to even touch them together. But I think these splints are really necessary to keep and hold what you have, because it's the only thing that will prevent a deep bite from deepening. If you've treated very long, you'll notice that all your deep bites eventually end up with a deep bite, even if they keep wearing the retainer. If you get to that splint, then it's going to hold it. And I wore a splint myself for many years, just testing the different ones. And it takes some people several weeks to get used to it. Some of them get used to it in the first night or two. But to stay with it, and if you wear that every night, it's a wonderful retainer. You fit it over your lingual wires, and you can even leave the tongue reminders on the lower. And it's a wonderful, wonderful appliance, and I would encourage you to look into that. Okay, well, without further ado, I'd like to turn it over to Dr. Kim. And I'm looking forward to hearing you, Dr. Kim. You going to use my computer? Okay, so